names are there as participants, but I really don't know whether you are there listening or sleeping or reading or talking. I don't know. But then if you want to be a good doctor, if you want to do something to the patients who have problems in eye, ear and nose, you have to use medicines, no? So this particular lecture tells you about those medicines. So even if you sleep now, which I have no control over, please achieve these learning outcomes by the time that you finish this module and before you become a doctor also. So there is at least about 3 or 4 slides on objectives, because I think 2 slides on eye objectives, no, 3 slides on eye objectives, 1 on nasal and 1 on ear. So there are 5 slides on learning outcome. I have an outline also, so you don't need to worry. So in eye, right, pharmacological aspects of medicine used in eye disorders, I am targeting only 4 things. One is the ocular dosage form. So in foundation module, we have taught you dosage form, solid oral dosage form, liquid oral dosage form, parenteral dosage form, like ocular dosage form. So one aspect of this lecture is ocular dosage form. Second one, glaucoma is primarily a disease of the eye. So therefore, I would just tell you the medicines used or recommended in the treatment of glaucoma. Okay. Then about steroids, because in all these conditions, even skin, eye, ear, nose, skin, steroids is a useful treatment. So therefore, something about steroids in eye disorders. And finally, something called dilating drops. Have you done ophthalmology appointment? Can I have an answer? Any students have done eye appointment?
Madam, some groups have done.
That's right. Enough. All right. So where is the male batch rep? Are you there?
I'm here. Yeah, madam, I'm here.
Oh, good. Right. Okay. So because the students who have done the eye appointment, they know as soon as the patients come to the clinic, even before doctor see the patient, the attendant drag the patient, keep the patient on a desk or in a bench and put some drops into the eyes of the patient. All of you know that. And after that, they don't explain to the patients also what is being done. After that, every 5 minutes, they come and put a torch into the eyes and see whether the patient is fit for the doctor to see. What they're actually doing is they are dilating the pupil so that the doctor can visualize the retina through the pupil clearly. So that is what the meaning of this drops putting as soon as a patient goes to the clinic. Now let us look at these 4 things. Ocular dosage form is very easy. It's mainly ocular dosage form of drops and ointment. So you have to understand the difference between drops and ointment and cream also. Drops are liquid. Ointment and cream are semi-solid. Whereas the proportion of water and oil are different between ointment and cream. So that I will leave it to you. Go and read. What is the difference between an ointment and a cream proportionate to the percentage of the water and fat or lipid or whatever, right? Which has more water content. Then in severe diseases of the eye, local application is not enough. We had to use oral or parenteral dosage forms, which we are not going to discuss today. So eye drops and eye ointment, again, I'm not discussing much about that. I'm just giving you 3 or 4 slides. I'm not going to read them also. How you advise a patient on how to apply an eye drop and how you advise a patient how to apply an eye ointment. And some of your grandparents might undergo cataract surgery. Post-cataract surgery, you have to apply eye ointment or eye drops to the patient. So you might be doing for your grandparents. So it is better that you know how to apply an eye drop or have to apply an eye ointment. And there is a homework also. So this is the steps. So I'm not going to repeat it. I will upload the handout there. So therefore you go through that, how to advise a patient regarding applying an eye drops, right? So I'm not reading that. So you can go and see. This is for eye ointment. This is the picture. So at least this picture speaks of volumes. So as you can see the ointment, so you have to wash your hands. You have to ask the person to look straight at you if they are standing or seated. Then what you do is you have to pull the lower eyelid a bit. Then with the whatever the nozzles of the eye ointment, without touching without the nozzle touching the inner part of the eyelid, you apply the ointment as a ribbon. You can see that. Then you ask the patient to do a massaging a lower eyelid so that the ointment will spread. Same mechanism as you can see for the drops. It's not applying a ribbon like ointment there. It is putting 2 drops. And also after that, rather than massaging, you have to ask the patient to keep the eyes closed for a while so that the drops will get absorbed. So that is what they are in the particular previous slides in a text format. So you can read that there. So this is the homework. Those who have done the eye appointment or those who are going to do eye appointment or even without doing that appointment, try to find out some common medicines which are available as drops or ointment and in what condition they are used like that. So remember that is a homework. We also give MCQs for the special senses module. And as you know, some students are actually missing a batch without going clinical science stream because they are not past the special senses module. So there is an importance because it's a last part of the applied science stream. There are only 2 exams that you have. So if you have not passed the special senses module in those 2 attempts, you might miss the batch. Right? Remember that, okay? Now we are going to the next one. So next one I told you about glaucoma. Right, so out eye, I told you 4 topics now. One is the ocular dosage form. Second one is the glaucoma. Third one is the dilating drops. And the 4th one is the steroids in eye. So again, aqueous humor circulation, I think you know that from the physiology. So where it is produced in the ciliary body. There is a picture later. It comes through the pupil and comes to the anterior chamber, nourishes the cornea and lens and goes back and get absorbed in the meshwork at trabeculae in the angle. So now that is the picture. So it's from I think it's from Google also. So there is nothing fantastic about this picture. You also can take it. I also can take it. So as you can see, the fluid is formed here. Then as you can see this arrow, it comes through the pupil, nourishes the iris and anterior segment of the eye. Then in the angle, through the capillary meshwork, it gets absorbed and sometimes goes here and gets absorbed here. Right? Part of it might get absorbed there, but comes out of this and get absorbed in the angle also. So here also the same picture is there, right, as you can see. Right? So what is glaucoma? Earlier days, we thought the glaucoma is accumulation of aqueous humor. But in the current concept, they say just simple accumulation of aqueous humor is not glaucoma. Glaucoma is more than that. It is a progressive retinopathy where there is a damage to retina. And that damage is more when there is increased aqueous humor also. That is what you have to remember. And glaucoma, generally we divide as primary open angle glaucoma or primary angle closure glaucoma. So here, if the iris pushes front, and if this angle is obliterated, it is a closed angle glaucoma. Okay? Whereas if that is not closed, but the problem is somewhere in the reabsorption, then it is called open angle glaucoma, right? So can you see that? So it's just problem in reabsorption at the trabecular meshwork. Angle is normal. It can spread through that angle. Then of course it is open angle glaucoma. If the angle is closed, then it is a damage is more and it is called angle closure glaucoma. As I said earlier, just raised intraocular pressure or increased aqueous humor does not cause glaucoma. It is actually a degenerative disease of retina. And if you have raised intraocular pressure, if you have intraocular hypertension, then what happens? The damage will be more. So therefore, two ways. Glaucoma can happen with normal intraocular pressure. High intraocular pressure can occur without glaucoma also. So the medicine groups which are used in the treatment of glaucoma, if you remember, I don't know whether I did the lecture for you, I don't think, medicine acting on autonomic nervous system in foundation module. Glaucoma is one characteristic disease where you see the indication and contraindication. What is the indication? Cholinomimetic and beta blockers are indicated. Okay? And cholinolytic and beta or sympathomimetics are contraindication. Cholinomimetic and sympatholytic are indication. Cholinolytic and sympathomimetic are contraindication. So pilocarpine, it is a cholinomimetic. Ecothiopate is a cholinomimetic. Different way they act, but they are cholinomimetic. One is a receptor agonist, other one is an inhibitor of destroying enzyme, that is cholinesterase, which increases the acetylcholine. Timolol is a sympathetic blocker, sympatholytic, so beta blocker. So cholinomimetic and sympatholytic are indicated. Cholinolytic and sympathomimetic are contraindication in the treatment of glaucoma. So not only the medicine which act on autonomic nervous system, there are other medicines also indicated in the treatment of glaucoma. Acetazolamide, it is a diuretic. It inhibits the carbonic anhydrase enzyme. Same mode of action for diuresis as well as in glaucoma, because carbonic anhydrase is necessary for the production of aqueous humor. Then clonidine, it's a not very commonly used drug. Other one is the commonly used one, latanoprost. It is a prostaglandin analog. I don't think whether it was taught to you in foundation module under autocoids. So I have picked up only latanoprost to teach you here. Okay, I have picked up only latanoprost to teach you here, because all the others, if you look at the slide, that has been done in another lecture. Okay, here pilocarpine, we have done it in autonomous nervous system. How does it act? It produces meiosis, because when it produces meiosis, it opens the drainage channel and improves the outflow of the aqueous humor. When dilated, it will be difficult to outflow. It is constricted, easy for the liquid to come out. Timolol, only thing is timolol doesn't act on the pathway of aqueous humor. Timolol beta blocker reduce the production of aqueous humor. Better to have a table, because this is a common MCQ question. How does the pilocarpine act? How does the timolol act? How does the acetazolamide act? As I told you, it is by inhibiting the carbonic anhydrase, and it reduces the production of aqueous humor. Latanoprost. So we'll move to the latanoprost. So remember, please, at least for the MCQ purpose, pilocarpine, timolol, then latanoprost. Acetazolamide is also used in glaucoma. So how does the pilocarpine? By causing meiosis, by increasing the outflow. Beta blocker by reducing the production. Acetazolamide also by reducing the production. But latanoprost, is actually increasing the outflow. So remember all these things, right? At least 4 of them. Cholinomimetic, meiosis, increases outflow. Beta blocker reduces the production. Acetazolamide reduces the production. Latanoprost is actually a prostaglandin analog. It increases the outflow. You can see that, right? So there is a little bit theory about latanoprost. The people who have done ophthalmology appointment would have seen this also, given as an eye drops, preferably administered in the evening. Side effects are there because it's a prostaglandin analog. Even if it is the ocular dosage form, systemic absorption is possible. And as you can see, it can be used with timolol also. Then I think I will give a break after I finishes. Then other two are very smaller section. So now, as I told you, in I will do 4 things: ocular dosage forms and glaucoma, steroids in eye diseases, and dilating drops. Now we have come to the steroids in eye diseases, one of the commonly used ophthalmic medicine. And it is indicated in inflammation in anterior segment after surgery or in. There's always a question why you are giving a steroid in infection. Because as you know, sorry, I will as you know, steroids are actually spread infection. It's an anti-inflammatory, but why you are giving is the same principle like you give steroids in meningitis, because it is an infection in a small area. So if there is a fibrosis, what happens is it can increase the intraocular pressure. It can even cause visual loss. So you can't afford to have a large amount of fibrosis in eye, in closed spaces. That is when in tuberculosis also we give steroids where the fibrosis might be damaging, right? Like peritonitis, pneumonitis, pericarditis, meningitis, but not just pulmonary tuberculosis. So here also it is indicated, it's how do you call it? It's a tricky thing. You have to use it with an antibiotic also, right? After surgery also, it is recommended to use with antibiotic, because if you use steroids alone, it might suppress inflammation, it might suppress immunity, and the eye infection can spread. So that is the reason of steroids in eye diseases. There are several dangers, as I told you. It suppress inflammation, can predispose to infection, long-term use, even ophthalmic preparation can cause cataract or glaucoma, right? Long-term use. So these are the preparation, right? So I will go back. Now I have come, this is not the one where I am telling about dilated drops. These are some other eye drops that you need to know. So you can refer that. I am not lecturing that. Now, can I send the text? So I'm keeping the phone on because 3 exams are going on. Final exam, A-Level 2015 as well as A-Level 2019. So that is why I'm keeping my phone on. So I'm sorry about it. Right, now we are come to the 4th section in the eye. That's what third section was ocular dosage forms. Second section was glaucoma. Third section was steroids in eye diseases. The indications are infection and post-surgery. And the 4th one is the important one. This is the dilating drops that the hospital attendant puts into the eye of the patients when they come to the clinic. Mydriatics mean drugs which causes pupillary dilatation. Cycloplegia means drugs which causes paralysis of ciliary muscles and loss of accommodation. So if you really want to visualize the retina using ophthalmoscope, not only pupils should dilate, but when you take the light close, there should not be accommodation, because that will hide the retinal view. So therefore, the best drug which can allow a doctor to visualize the retina through the ophthalmoscope is a mydriatic plus cycloplegic, pupillary dilatation and loss of accommodation. So that is what most of the eye drops have, a product which can cause both. So therefore, what happens is we manipulate the drugs acting on autonomic nervous system to get this action. So as you know, sympathomimetic causes pupillary dilatation. In my on-site lectures, I always tell you, so if I come for the lecture, your pupils get dilated because your sympathetic nervous system is stimulated. So therefore, but sympathomimetic will not cause ciliary muscle paralysis. Sympathomimetic will cause only pupillary dilatation. Whereas the opposite one, that is the antimuscarinic, can cause both mydriatic and cycloplegic. Mydriatic and cycloplegic. So the best option to dilate the eye is actually antimuscarinic. So now, sorry, right? So I will come to that, but I just want to put the table. Yeah, so this is the table. So phenylephrine is a sympathomimetic. So it has only the mydriatic action. All the others are anticholinergic. They have the mydriatic and cycloplegic action. The most commonly used eye drops in our hospital is tropicamide. So therefore, next time when you go to eye appointment, when you see attendant putting drops into the eyes of the patient, just take the vial in your hand and read it. It is tropicamide. So it takes about 20 to 30 minutes to get the effect. That is what with the torchlight, the hospital hall attendant, because it is exam now. So I remember always exam. So the hospital attendant goes and put the torch and see whether it is adequately dilated. But the effect will last 3 to 6 hours. So if you see a patient after the clinic, you see their pupil would remain dilated. And that might cause visual blurring. So that is what, when you have been administered this dilating drop, you have to advise the patient, you will have some form of blurring of vision. Better to avoid driving for about 6 hours after the eye drops were put. And also to avoid going in staircases or heights after the eye drops have been put. Right? So nothing is told to the patient, you know that. So that is our healthcare system. Everyone boasts that we are doing the best to the patient, but this particular small information is not given to the patient, which is very important. I have given that in the slide before. You can read that, right? So what happens and how you had to advise the patient and everything is there. So because it is theory, I didn't explain, but that you have to remember. All right. Now I will give a small break. So again, we have done the eye component. And the eye component, we did 4 things. 1 is the ocular dosage form, drops and the ointment. 2 is the glaucoma, definition of glaucoma, connection between glaucoma and raised intracranial pressure, circulation of aqueous humor, then the classes of medicine which are recommended in the treatment of glaucoma, and latanoprost in detail. Then we went to steroids in eye disorders. And I explained to you what are the preparation, what are the precautions, what are the indications. Then we went to the last one, that is the important one in practical purpose. What do you call these dilating drops, right? So the dilating drops are actually which has mydriatic as well as cycloplegic action. And they are mainly anticholinergic. And these anticholinergic are examples I have given. But we select tropicamide because its maximum effect is given about 30 to 60 minutes and its effects last only for 3 to 6 hours. If you give atropine, pupil will remain dilated for 1 week or so. Okay. So now I will give you 1 minute break. Okay. If you are listening to this lecture, you can take a break. Right. Now we have come to the nose. From the eye, we have come to the nose. I'm going to teach only 2 topics in the nose. Probably these are the 2 medicines which are used through the nose for indications in nose, right? Right. So there are some other spray which we use through the nose for some systemic diseases. But these are the 2 preparations which are used through the nose for the conditions in the nose. One is the steroids, other one is something called decongestants. Congestion means it's vasodilatation and the swelling of blood vessels or capillaries in the nose. So that is what you call blocked vena cava, right? So I used to say that if you're on site, you will understand what I'm telling. Most of the doctors who are working in small areas earn money because the nose is blocking for a lot of children. Right, so the mother takes the child to the doctor and say, I can't tell it in Sinhala, but nose gets blocked, then the doctor gives to some drops or whatever. So keep on, the mother goes there and the doctor become rich. So that is what this nose block. But if you wait about 2 to 3 days, the nose block will get automatically relieved. When they come to me, I never give medicine. I chase them also. I scold the mother also, telling that these are simple things. You don't need medicines for this condition, right? So, but anyway, as a pharmacologist, we need to know what they are and why they are there. But clinically, the use should not be that widespread because it all self-limiting conditions. But then if you are asked to be careful about steroids, because if you are a good student or if you are interested in learning, go and revise the indications of steroids, right? You can see it in all the system, right? In all the modules, we would have taught you steroids at least for one indication. So steroids is that important, so remember that. So therefore, in nose, what happens, steroids is mainly indicated for allergic rhinitis. You know what is meant by allergic rhinitis? That is, people tend to sneeze or sometimes nasal drooling because they were allergic. It's not a form of an asthma. Asthma is a bronchoconstriction. This, of course, inflammation of the nasal mucosa. So the medicines, almost all the steroids are available as a nasal drop also. So it is here. And what is the mode of action? You know, it's anti-inflammatory, decrease the capillary permeability. So the swelling reduces, mucus secretion is reduced. So whatever which is coming out will stop, right? So that is the action. So it is like same action it has it on asthma also, right? Why we use beclomethasone inhaler in prophylaxis of asthma is in a form of inflammatory and immune suppression. Here also it is a inflammatory suppression because the symptoms of rhinitis are mainly due to inflammation. Side effects are there, so you should not apply too much because it can get absorbed. All these dosage form, a small proportion of that can get absorbed in the systemic circulation and can produce systemic adverse effects. Famous MCQ again. Nasal dosage forms are free of systemic adverse effect. Mean answer is false or common MCQ. So there are side effects I have given about steroids in nasal diseases. And these are the cautions and some other practice points, right? And also, if you can see this bullet point, this is mainly for practicing doctors because all the drug companies which produces nasal steroids go and encourage the prescriber saying, my product is better than their product, but all nasal steroids are equally effective. So remember that also. This is what I told you, topical decongestant. So congestion is actually the nasal block, right? Sometimes, you know, people, as we say, they are speaking through the blocked nose. So that is the blocked nose. So nose block. Big problem for mothers in this country, the nose block. For me, it is like a simple instance in a baby. It just happens. But a lot of doctors can earn a lot when the parents take the children saying that block quinoa, right? So what as I am telling is my advice to the parents is take a white cloth, dip it in a warm water and give a good massage to child's nose so that whatever there is a block will be get cleared. If there is mucus, that get cleared. So that is the advice I give to the parents. I don't prescribe medicines, but then there are medicines which might speeden the process. That means it might relieve the symptoms sometimes little earlier than my home remedy. So therefore that group of medicine, because it is congestion is vasodilatation now, so therefore the medicine which causes vasoconstriction mainly used as a decongestion, that is a sympathomimetic drugs because they cause vasoconstriction, especially the alpha sympathomimetic. Here please listen to a story. I didn't put the slides. Maybe about 10 years before in Lady Ridgeway Hospital, about a 6-month-old baby was admitted for some form of upper respiratory tract infection or something, if I remember. But then when they were examining, they found the child's, the infant's heart rate was quite high, right? About say 170 or 180. So they all got anxious, the doctors. They got a ECG also done. In the ECG also, it was sinus tachycardia, just tachycardia. No other abnormalities were there. They couldn't find a reason. They sent the baby to echocardiogram. Also, echocardiogram was also normal. But then, when we took the medicine history, we found out the child has a nose block. Mother has taken the child to the doctor. Doctor has prescribed silometazoline, which is a sympathomimetic, without advising the mother how to put that. Mother gave it by mouth to the baby without applying through the nose. So therefore, a large proportion of medicine has reached the systemic circulation through the stomach and has been responsible for that tachycardia. So these are small things a doctor can do. So because it is a sympathomimetic, that sometimes that it can cause other symptoms as a side effects. You can see irritation, nausea, headache. So sometimes the side effects might be more than the nose block also. So that is what I advise. I try to avoid prescribing these things for small kids, right? So caution and contraindications are also there. So now we have moved to the ear. I am also going little fast, I know that, but that is to release you as well. So we will take a next break, right? About 2 minutes break. So eye has been done, 4 conditions. One is the eye ophthalmic dosage form. Second one is the steroids in eye. Third one is a glaucoma. And the fourth one is the dilating drop. Then we did the nose. In the nose, I taught you only 2 things. Number 1 is steroids in the treatment of nasal, nasal symptoms. And the second one is the topical decongestions. So that is mainly sympathomimetic, right? The next part is ear. Under ear, we will be discussing these things, but I will give you again a small break. Okay, we'll back. So under ear, we will discuss 4 topics because otitis media I have not discussed here because otitis media is actually a systemic type of infection. So we will not consider it as a local ear condition, and the treatment anyway is a systemic antibacterial agents. So I'm not going to discuss otitis media in this lecture. So here what I am discussing is again 4 things. Removal of ear wax. So hope all of you know what is meant by wax. Second one is steroids and antibacterial agent combination. Why I put like that is you hardly get a steroids only preparation in ear. Even eye is the same, even skin is the same. That's actually not correct because when we are looking for a steroids only preparation, how do you call, unintentionally we are buying a steroids and antimicrobial combination which exposes the environment to antibiotics and increases the resistance also. When you need only steroids, why do we need to put steroids and antibiotic together? But unfortunately, the pharmaceutical industry determines it. They don't market only the steroid preparation most of the time. right? Even if I write and give, the patients come back and say, Madam, steroids only is not there. It is with antibiotic. So the child doesn't need the antibiotic, but I don't have a steroid only preparation in Sri Lanka. Then I had to give the combination that actually increases the antibacterial exposure into the environment and increases the risk of antibacterial resistance also. So these are pharmaceutical industry induced irrational use of antibiotic. Earwax, you know, it is a normal secretion, but if it becomes thick, sometimes it can cause deafness. I have seen patients having deafness because of earwax, and once the earwax have removed, they ask us, why are you shouting? Right? When the earwax is there, we shout. Earwax is removed, when we talk at the same tone, they ask us back, why are you shouting at me? That is because the earwax is removed. So for adults, I don't know, again, the people who have done the ENT appointment would have seen that they do something called syringing. That means they put water, warmed water to match with the body temperature and allow that to get sort of there in the ear for some time. Then it is syringed out. So when you syringe out, the water plugged together with the whatever the secretions might come out. Whereas for children especially, we don't allow this syringing because it's a bit scary also. So for the children, what we advise is we put some olive oil or sodium bicarb or even almond oil or whatever, and that's what I advise to all my children who comes to me, and keep the child allowing the affected ear to be kept up for some time. So that means during that period, this wax get dissolved, and then ask the baby's head to be lifted and turned to this side. And when the oil leaks, with that the wax also leak, and then you clean it. So that is how I advise the parents, but I ask them to do regularly, say every two months or something like that, so that the wax will not get accumulate and it will dissolve. Because once it get accumulate, it's very difficult to remove by the mechanism I told you, right? So sorry. So these are the things. Syringing is not. Can you see what I have written about syringes? But then you have a YouTube also, you can easily put and see what you mean by syringing of wax. But as I told you, syringing have to be avoided in young children and who have recurrent otitis externa and eardrum perforation, because water can go inside. And if you have a ear problem in the other ear, because you don't want to damage this ear accidentally even, because the other ear is not working. So these are the products, as I told you, simple remedies, olive oil or sodium bicarbonate, but the pharmaceutical industry preparation also there. Can you see the name? It is called ceruminolytics because the wax is actually a cerumen. Because in MCQs, again, we might ask by example of ceruminolytics, then don't get confused and put the hands up and ask the supervisor what is meant by this. Even supervisor might not know that, right? So remember that. So that's the first one, removal of earwax. The second one is again in ear, steroids. As I told you, steroids only preparation is hardly available. We are forced to prescribe both together, steroids and antimicrobial combination. Then under indication, steroids and antimicrobial. Otitis media is not here, but otitis media, we don't prescribe steroids also. That's a systemic antibiotic. So in otitis externa, chronic suppurative otitis media, that means otitis media, now it has become chronic, burst, eardrum has burst, now the pus is coming out. So it's almost like an externa. The infection is now not limited to inside. Other thing is, I don't know whether you know about in ENT, there is something called glue ear or serous ear. When there is a large amount of pus accumulate in middle ear, intentionally the ENT surgeons perforate the eardrum and allow the pus to be drained outside and put a small tube there, like if you do, I don't know whether you know, when you do a surgery also, sometimes you put a small catheter now. So for the whatever the things are inside to come out post-op, like that, they also leave a small tube. So that is the one, discharging ventilation tube. So that's a name as well, but the common name is ventilation tube. So the ENT surgeons believe if you put a tube like that, whatever the pus or the liquid accumulated on the middle part of the ear would come out. But to prevent any further infection, you can apply steroid antimicrobial combination. Perforated eardrum is equal to this discharging ventilation tube. Perforated eardrum means because of the infection it perforated. Discharging ventilation tube is we purposely penetrate that for the pus to come out. So therefore, that is what you have to understand. But when you see antibiotic plus steroid combination, avoid aminoglycoside combination, because if there is a perforated eardrum, aminoglycosides can go in and can cause ototoxicity. So these are the adverse effects of this steroid antimicrobial combination. There are some preparations. See, most of them are with the aminoglycoside. So we have to be very careful if the eardrum is already perforated. These are the steroids only preparation, but as I said that they are not available in the market commonly. Next one, otitis externa. It's an infection of external meatus. So it's almost considered as an outer wound because it is connected to the external area. So it is treated like we treat a wound also. But only problem is you can't put an antibiotic and keep it there in otitis externa because it might leak out. So that is, or you may have to put it repeatedly. Because you cannot do that, so what I don't know whether you have, just I will hold on. I want to show a picture. This is the last one. So you can see, I know when I was doing ENT appointment, every patient has something like that. If you can, sorry. Ayyo. I don't know, what did I do? Sorry. Because when I was doing appointment, ENT appointment long before in the hospital, so very strict ENT surgeon also. Every day he scolds us. But then we see almost all the patients have something like that in the ear, and the nurses always prepare a sort of wick-like thing here so that wick is soaked with an antibiotic that you want to give. And as you can see, the wick is put inside here. So that is there. So then with the syringe or whatever, some drugs can be dropped into the wick, which will diffuse and reach the external meatus. So the principle is you can put a drop there and keep it there. So it comes out. So you cannot just treat like you treat our skin wound. So that is what they have, this novel preparation which helps to keep the drug there. Sometimes only the gauze will hang, and maybe 3 times a day the patient would be asked to drop an antibiotic in the gauze, which will diffuse and try to enter the external area in the ear. So otitis externa generally treated with topical condition, but it's very painful. Again, I don't know whether they have taught you in ENT surgery, ENT appointment. When I was a student, they say you pull like that, they will scream. So then we as a student say, even if there is no otitis externa, if you pull like that, everyone will scream. But the teachers taught us, the consultant taught us, the main cardinal feature of diagnosing otitis externa is it is painful, and sometimes you can see a red area around the ear, and that means the infection has come outside and there is a mild amount of cellulitis. Then of course you need an antibiotic. That means systemic antibiotic. But if that not has come out, then you can manage with topical antibiotic. But because you cannot apply the topical antibiotic, I showed you the way how these topical antibiotics are applied in the otitis externa. So that is the last one. So what do you call ear preparation? You may have a here ear drops, you have ear ointment, you have ear solution, but the last one is the interesting one, what I told you. There is a ribbon gauze, right? So you roll it, make it as a wick and put it there with the antibiotic or antibiotic steroids, And 3 times a day, you can apply the drops onto the gauze, expecting that the medicine will diffuse through the gauze to the external meatus. Right? So this is what I told you. These are all obtained from Google. So you also can obtain from Google. So that finishes the lecture. I think I finish it early for intentionally because this lecture is just theory and you can easily read the handout also. And to revise again, as you know, so there are 3 conditions. One is related to eye, one is related to nose, one is related to ear. Under eye, ocular dosage form, how to administer the drops and the ointment. Under glaucoma, circulation of aqueous humor, definition of glaucoma, medicine classes indicated in glaucoma, and little in detail about latanoprost. Then steroids in eye diseases, what are the indication, what are the contraindication, what are the precautions. And finally, in the eye, dilating drops, very important, mydriatic plus cycloplegic, mainly cholinomimetic. And I have given you several examples and the precaution that has to be taken and the peak effect and the duration of action of each and every dilator drop that I have given in the slide. Commonly used in Sri Lanka is the tropicamide. Then we moved on to the nose. Only 2 indication I taught you. One is about steroids, other one is about decongestion. So I taught you about the nasal steroids indication and the precaution. Then I also taught you about decongestion, sympathomimetic indications and precaution. Then we went to ear. In the ear, mainly wax removal, ear dosage form, steroids and antibiotic combination, and otitis externa, right? So this is the maximum that I can do for this lecture. I hope that I have given the content as much as possible, and I am compared to the previous or whatever, I can see about 128 students there for 315 lectures. So thank you very much. Even if the rest are not attending the lecture, I'm very grateful and happy that at least 130 students have been, signed in this lecture. Whether you have listened to the lecture or didn't listen to the lecture, I can't help it. I wish you all the best and let us wind up this lecture. I will upload the handout in your LMS folder under Special Census module. Thank you very much and all the best. Have a nice evening.
Thank you, madam.
Thank you, madam.
Thank you. All the best.